Today we'll be discussing management of patients with a BRAF mutation with a history of non-small cell lung cancer, and talk about some of the unique features of this particular mutation and management of these patients. To highlight some of these differences, I'm going to present a case and then discuss the management of this particular patient, and again, talk about how we usually approach a patient with non-small cell lung cancer and a BRAF mutation. The case involves a 69-year-old male who comes in with a chronic dry cough and dyspnea on exertion. He has a past medical history of hypercholesterolemia, and he has a history of a 20-pack year smoking. He quit about 6 years ago. His hypercholesterolemia is under control with medical management. On physical exam, the only thing that is abnormal is that he has decreased breath sounds on auscultation. In terms of the clinical workup, his labs are within the normal limit. His chest x-ray shows a solid mass about 4 centimeters. This is confirmed by a CT scan that shows a 3.7 centimeter pulmonary nodule in the right lobe. He has IPSI, lateral mediastinal, and subcrinal lymphadenopathy. And then he undergoes a bronchoscopy for tissue acquisition and diagnosis. And unfortunately, he's diagnosed with a metastatic lung cancer, adenocarcinoma subtype. MRI does show a small brain lesion. He then undergoes molecular testing. His PD-L1 comes back as having TPS of 20%. And his EGFR and ALK and ROS come back as being negative. However, he does have a BRAF V600E mutation. He is then staged as having a T2A N2M1B metastatic adenocarcinoma with a BRAF V600E mutation. He's got an excellent performance status. So this, I would say, is a fairly typical patient who comes to our clinics. This patient then was started on targeted therapy with a combination of dabrafenib, which is given at a dose of 150 milligram PO twice daily, plus trametinib at a dose of 2 milligram PO on a daily basis. And he achieves a partial response and has been able to sustain this. As far as side effects are concerned, he has grade 1 fatigue, which again is common for this type of therapy, but he continues on treatment without any other significant toxicities. Imaging is repeated at 3 months, 6 months, and 9 months, and he still has a sustained partial response. So this case highlights several important things. I think the one thing that we have to get out and discuss is that we would not be able to manage these patients with targeted therapies that are well tolerated and are highly effective if it wasn't for the molecular testing process. Therefore, I think one of the most significant things that and I'd like to highlight about this case is that everyone with a history of metastatic non-small cell lung cancer who comes to a clinic should undergo extensive molecular testing to find these mutations. Overall, the literature suggests that BRAF mutations are found in about 2 to 4% of all patients with metastatic adenocarcinoma. It is not a large number. We realize that. But I think going through the case and reviewing the literature, hopefully you'll see that it is important for the well-being of the patients that these minor mutations, if you want, are also detected. We all have heard stories about EGFR, ALK, and how effective these treatments are. And I think we're learning that there are more and more of these sort of driver mutations or targetable mutations for which we have very effective treatment options. And again, I cannot emphasize how important it is to have the molecular testing done in virtually 100% of our patients who come in with a diagnosis of lung cancer to be able to find these minor mutations.